I'm recording this after I've recorded the whole video. If you watch this video because you're bad at taking histories, you need to go and take histories. Go write. There's a link to the PDF that I've been using. I'll write up this PDF. Go and read this book, and then go and do some histories, bro. That's the only way to get better at taking histories. That's it. Call up your friends. Be like, look, pretend to be a patient. Pretend to be a gynae patient. Let me take a history, for God's sake. Pretend to be a obstetric patient. Let me take a history. It's not difficult. You know, this is a great framework if you were year 1. But if you're like year 4 and you're watching this, which I hope you're not, you need to lock in, bro. Legit. Okay, I would love to go and doom scroll for 4 or 5 hours, but this is how to take a thorough, comprehensive gynae history. So I'm going to be using Impey to help me out. Great textbook. So the principles of gynecology are embedded in dignity, just getting as much dignity for the patient as possible, keeping her comfortable, them comfortable, keeping them as dignified as possible, and because of that they'll maintain their trust in the healthcare profession and therefore be willing to offer more information and be as comfortable as possible, and that's the best outcome for the patient at the end of it. So privacy, confidentiality and dignity, and along with that comes a chaperone if needed. I've done quite a few clinics outpatient, and then I've done a hysterectomy clinic and a hysteroscopy clinic. Not a hysterectomy clinic, like a hysterectomy list, but there was like one patient that I actually got to go and see. But respect and dignity always maintained. It's a common theme, no matter what trust you go to and no matter which consultant you're working with. So cool. Moving on, you want to be using open-ended questions. You don't just want to be asking yes/no questions, and also ask questions one at a time. Ask the question, let them answer, and because what that will do is when you ask like multiple questions at once, like when was your first period? Was it heavy? Was it light? Was it painful? The patient usually tends to just answer the last one, and then you kind of miss out the other 2 questions. So that's something you want to be aware of. Non-judgmental, don't make any like weird facial expressions. It can throw patients off, and then that'll sort of ruin everything for the rest of the history. And making sure you're noting down the patient's concerns in their own words. So yeah, going through chapter 1 for the history in the exam. We won't do the exam today, obviously. I don't have the resources here anyway. We want to be asking her name and age, but we don't just want to be making it like checking the box off. We want it to be kind of like a flowy kind of conversation. So ask the name, age, and then also what Impey suggests here is asking the occupation as well. Just to sort of build some rapport with the patient, which is the most important thing, making them understand that we're here to empower them to take control of their own health, which is the most important thing, of course. Moving on to the actual gynae history, we want to be asking about the presenting complaint. Why have they come in? How long has it been going on? How bad is it? How often does it happen? Some of the more common things that I've seen in outpatient clinics specifically is incontinence in some of the middle-aged ladies, but it can happen just as much in the younger ones as well. Postmenopausal bleeding, perimenopausal bleeding, bleeding on contraception, pelvic pain is a massive one. And some of them and some haven't been linked to endometriosis, I found out afterwards. So it's a really wide range of presentation that you can have when it comes to the patient. And then with each one, you want to go back to the history of the presenting complaint. So if it's pain, you want to take a thorough Socrates, so site, onset, characteristics, radiation, associations, time, exacerbations, severity. I think, anyway. If I got that wrong, that's going to be so awkward. But anyway, and make sure that we clarify the cycle relation with the patient. So specifically, if it sort of corresponds with the cycle and which days of the cycle it sort of corresponds to. That will be really important, because in things like endometriosis, for example, the pain is worse at certain points in the cycle because it's linked to the hypothalamic pituitary axis, HP axis, I think it's called anyway. So when we get to the menstrual history, which is the next part, we're going to be asking the age at which the menarche happened. I think it's menarche, I'm not sure, but yeah. So when did the patient get the first period? And then the cycle length, the duration and flow. Was it light, heavy, or normal? And that will be up to the patient to let you know how it is. So heavy period for them might be different to what a heavy period is for someone else, and so forth. But keeping note of any bleeding between the menstrual cycle, or if there's bleeding after sex, for example, that's really important, and that's something that we want to be asking about. When was their last period? This is a big one because it's difficult to, with the menstrual history specifically, when you're taking histories back to back to back, like for example when you're doing a list, for example, it can become rather monotonous. So you don't want to get to that point, otherwise it kind of just becomes a back and forth with the patient, and while some patients might appreciate that you're just getting to the point, some really don't, and they kind of just feel like they're being checked off boxes. So that's something to look out for when you're taking this history with regards to some of the middle-aged and elder women, but it's also possible in younger women as well. Rarely. The menopause age should be asked as well, just in case there's a possibility of them going through menopause as one of the reasons for their symptoms. So they could be perimenopausal, postmenopausal. We want to be asking about any kind of discharge that the patient's getting. So with discharge, we want to be asking onset, how long it's been going on for, what's the colour, what's the smell, any volume, what kind of volume it's coming out of, out at, and then also any associating itching or pain. And then also it'll come back to the sexual history as well, but asking about any past STIs here, but introducing the topic very calmly and sensitively is the best way to approach it, if it's relevant. So coming back to the urinary and bowel symptoms, so this is quite important with patients that might be presenting with incontinence. So incontinence, the urgency, the frequency, any kind of dyspareunia, painful intercourse, okay, or any kind of rectal symptoms. I just saw a case the other day of a patient was having a lot of post-intercourse UTIs, and it was like a common thing for her. I can't remember which organism, I don't know if it was a question on the organism, but it was like how would you treat it, basically? And it was like either Cipro, Nitro, ciprofloxacin, the fluoroquinolone we sometimes give for UTIs, and nitrofurantoin is usually first line at the time of this video anyway. But it was actually, the way to treat it was giving a single dose of nitrofurantoin after each time the patient would have sex. So that was quite interesting. So your sexual history can actually have to do with other presentations as well. So that's something to always look out for. I don't think that something is irrelevant per se. Coming back to the gynecological history, any past surgeries. So usually patients sometimes need some clarification on what is a past operation and so forth. So a good kind of leading question with that is, have you ever been in hospital before for anything? And they appreciate that question because it can sort of simplify things for them, and it kind of removes any kind of medical jargon and that kind of invisible barrier that occurs between the patient and the doctor. Moving on to the contraceptive history. If the patient is on contraception, or if they've ever been on contraception, or they're looking for contraception, we're going to be asking the current and previous methods that they've been on, if they've ever had any side effects, if there's ever any issues with compliance. And there's a big one with the combined oral contraceptive pill. There's a whole, I think it's men? No, not men too. It's like a UK MEC. It's basically a big list, and there's like category 1, category 2, category 3 for reasons why a lady can't take COCP. So that's something that you should really read up on and be aware of when you approach it with the history. And then the reasons why a patient would want to change contraception. I don't even know where HRT came from. It's literally not on any of my notes or on the screen either. But yeah, another big one is the cervical smear. So that's some screening that we do regularly here in the UK anyway. So are her smears up to date? That's a big one, and it comes up a lot in the outpatient clinics as well. Are the smears up to date, and has there ever been an abnormal smear is the next question that you'd ask. And then coming back to, again, sensitively introducing the sexual history, asking the number of partners, whether there's contraception being used, what method of contraception they're being used, and any history of STIs. And again, it comes back to whether there's any pain with the intercourse as well. Introducing it really sensitively is the key here, because if you treat the subject as quite serious and concerning, as serious as you take the subject is how serious the patient will take the subject, and that tone will sort of carry over. So being calm, being collected will carry over to the patient as well, especially in this sort of outpatient clinic setting anyway. Moving on to the obstetric history, this is where it can get a bit complicated. There's some terms here that you probably need to double check if you don't understand, but we'll go through them anyway. So you see like a G and then a number and then a P and then a number. So the G is gravidity, and I think it's like gravida, sometimes it's shortened to. I don't know if it's Latin or not. Etymology. Yeah, Latin for gravidus, heavy or burdened. So that's quite interesting. And so gravidity is basically the number of pregnancies. So if you want to think about using the Latin term, gravidity is how many times a woman's been really heavy, because women will tend to gain weight in pregnancy. And then parity, that will come to the number of times she's given birth, specifically after 24 weeks, whether that was live or stillborn. And this will include any miscarriages and terminations which you want to ask for, and again being really sensitive with how you introduce that topic. With each pregnancy, so let's say the woman has 2 children, for example, you want to be asking when it happened, so the year, and how did it go. So was it sort of a vaginal delivery or a C-section? If it was a C-section, was it an emergency or was it an elective? So did they plan it out being elective and then emergency? Was it like, did it just happen spontaneously? Was there any complications? So does the patient have any history of preeclampsia? Preeclampsia is basically a condition where the patient has high blood pressure and, well, I'm being tested. It's basically high blood pressure of the patient, and it like reduces how much oxygen is getting to the baby, and so it can cause complications in pregnancy, as far as I'm aware. Correct me if I'm wrong. And again, with the labour, was it spontaneous or induced? And the neonatal outcome as well. So how did the baby turn out? How much did the baby weigh? What was the baby's APGAR scores at what times? And did the baby have any NICU admission? So neonatal intensive care unit. Another thing is if the baby had VIT-K, that's something that they ask, and also the head circumference. I worked in a surgery a few months ago, and I was coding into EMIS a lot of like discharge letters for the neonatal unit and the antenatal unit, sorry. And it was like head circumference, the baby's weight, the gestational age of the baby. So you see a lot of 36 weeks, see 35 weeks, see 31 weeks, saw 39 weeks once. But yeah, and then asking about the lady's plans as well, so breastfeeding, postnatal depression. Not that she's planning for postnatal depression, wow. Was there any complications like postnatally? And it slipped me now. The women's self-care. I remember in my OSCE at RCGP we were doing, there was a case, and essentially I misworded it. I was like to the patient, have you been keeping clean? And the patient kind of gave me a look like, what do you mean am I keeping clean? And then I was like, oh, that's so awkward. But then I was like, no, I doubled down. So I doubled down. I was like, yeah, have you been keeping clean since you had the baby? And then I got some really good feedback afterwards about how it's better to introduce it on a self-care type, and can I level with you about your self-care? How has it been ever since the baby? Have you been looking after yourself? Such a better way of putting it, instead of have you been keeping clean? that's so poor from me. Moving on to, and then it comes back to the sort of the general history, the past medical, surgical, drug history, patient on any medication. Has the patient ever had any medical conditions? Does the patient have medical conditions? Which it will come to. Is the patient suffering with anything chronically? So stuff that we need to be aware of. Does the patient have hypothyroidism, for example? They're being supplemented with thyroxine that we need to be aware of. Usually we increase the dose in pregnancy. I think that's usually done by a specialist, but I think a GP can do it as well. I'm not 100%, double check me on that. Checking for any previous surgeries and also their allergies as well. Big one, how can you forget that? Coming back to the idea of a family history, so are there any inherited conditions such as breast cancer, ovarian cancer, thrombophilia? Is there any kind of blood clotting disorders that we need to be aware of that could potentially put the pregnancy at risk, that could also potentially have to do with their presentation today? And asking about relatives with any infertility or early menopause. Coming to the social history, so again, introducing it really sensitively. I know these questions might not seem relevant, but it's just to get a bigger picture of things and help to get the best care possible, just to get as much information as possible. Again, let them know they don't need to answer the questions, but it will help. I rarely see a patient that refuses to answer a question, especially when you've built a good rapport with them and so forth. If it's like right off the bat, completely understandable, you know, they don't trust you, they don't want to see you, whatever. Especially in my experience, being a male on some of these rotations, kind of get asked to leave sometimes, but you know, sometimes you're very lucky and you get asked to, you're fine to stay as well. So that's always good. I think I've only been asked to like leave like 3 times since the last 2 years. Which I'm always really privileged to think about. So yeah, the social history, we're thinking about their occupation, so something that we asked right at the start, seeing if that has anything to do with what's going on here, and if they've got a good support network as well with regards to the occupation. So if they're working quite, let's say they're a freelancer, they're quite isolated, you know, is that affecting anything that could be going on with them? Coming on to smoking, alcohol, and recreational drug use, again, emphasize that it's just for information, it's not for... We're not going to be judging you, because it comes back to the first thing we said, no judgment here. And then also safeguarding concerns. So if they're pregnant and they've got a partner, have they got any bruises? You know, you really need to be diligent in what you're doing. Diligent in that this patient's under your care. So keep a lookout basically on being diligent. You know, is this patient really in the best state they can be right now? Try and pick up on non-verbal cues, verbal cues. Body language, are they here with someone, is anyone answering for them? That's a big thing as well. But yeah, I think that does cover most of it. Coming back to the book, yeah, you want to do a systems review, usual cardiovascular, rest, neuro questions, any trouble with your vision, shortness of breath, chest pain. Those are like sort of the start off, and then you can spread on. If there's any urinary or GI symptoms, so abdominal pain, that will come with some of the presentations that they have. Family history, so breast, ovarian carcinoma, VTE, venous thromboembolism, like a blood clot in the leg basically, or pulmonary embolism, for example, heart disease. And then, especially leading on to the exam, you want to ask about allergies, as we mentioned, but also penicillin and latex you want to ask for. But yeah, coming back to the summarization, we want to use the words just to make sure I've understood, and then regurgitate back as much as you can remember. And then if there's anything that doesn't sound right, the patient will usually correct you, and you can go over the notes that you've been making if you've been making notes, and try and use the patient's own words where possible. And then coming back to this ICE framework that we get taught at KCL, but a lot of places use it as well. So you don't have to necessarily say what are your ideas, but also what do you think, and what are you worried about with concerns? What are you worried about? What's the worst thing that you could find out? What's your biggest fear? Because it's usually a case of, not usually a case, but there's points where a patient doesn't necessarily need to feel alright, like they can deal with the symptoms, but they just want to make sure that there's nothing like severely wrong. Like they want to, not every single patient needs to be treated. It's something you learn, something that I'm still learning. While there's a treatment option available, not every single patient would opt for it or want it, essentially. And then the expectations, of course. You know, what are you expecting from me, or what would you like to happen, and yeah, I feel like that really comes back to this idea that we're empowering the patient, especially nowadays. Medicine is not what it used to be. Especially, I hear that especially in the surgical world as well. There's a lot of regulations now, and it's not what it used to be, and for good reason as well. But I think that's everything with regards to the gynae history. If there's anything you can think of, let me know, and if you found it helpful, let me know either way. But yeah, cool guys. Okay. I do speed runs of PassMed. I'm live on YouTube. You can check me out if you want.